Goldie, your microphone is on.
Madam, namaskar. Good afternoon.
Hello.
Good afternoon, ma'am.
Yeah, very good afternoon, sir.
New caption visible.
Say, Rashmi Garu.
Goldie, your camera is on.
So shall we be
Yeah, you can
starting?
start, ma'am. You can start, ma'am.
Okay, fine. So the first session I will take is the infection prevention and control, and then I'll move on to the next one. I hope my slide is visible to everyone.
Yes, ma'am.
Okay. So a very good afternoon to all of you, and I welcome you all in the discussion for the basic principles of the infection prevention and control, and how it will be impacting our daily life. That we'll see, and how we can implement it, monitor it in our premises or our healthcare settings. So I am Dr. Sumita Soni, and I am working as an associate professor in Department of Microbiology at BJ Medical College, Ahmedabad, and also I am the infection control officer of Civil Hospital, entire Medicity campus, Civil Hospital, Ahmedabad. So first of all, before the concept of the IPC, which we call nowadays, that is what is called as an infection prevention and control. Previously, it was called as a hospital infection control program. So the entire concept has come through the increase in the number of the healthcare associated infections. So, what is first we'll try and learn what is a healthcare associated infection, and I think that this is really a very apt time when this entire session has been organized, because this entire week we all are celebrating the week for the antibiotic awareness and infection prevention and control across the globe. From 18th of November to 24th of November. So healthcare associated infection is anything, like it was not previously present when the patient got admitted for some other disease, and it was not also present or incubating at the time of admission. It has got, these all are synonyms, but now we use the term healthcare associated infection. Previously, we called it as hospital acquired, but now it is not only acquired, but it is associated, and it is caused because the patient gets these sort of infection when they come and they live for a longer period in a hospital environment. So it also includes the occupational infection among all of us. The synonyms are the nosocomial infection, hospital infection, healthcare associated infection, hospital acquired infection, anything can be used. So, targetedly, if you are supposed to calculate and count the healthcare associated infection, we all are, WHO has given one definition that if a patient is admitted for 48 hours or more than 48 hours in a healthcare settings, and if a new infection occurs, maybe it is attributable to the hospital environment, and we say it as a healthcare associated infection. This entire infection basically is dependent on one triangle, which is we call as a epidemiological triad or epidemiological interaction triangle. And herein three important factors are there. One is a host, second is an environment factor, and third is a agent factor. Okay, so mostly we all know in how what type of patient get admitted in a hospital setting. They all are mostly having comorbid condition, underlying disease, nutrition is poor. So these sort of patients are more susceptible to the healthcare associated infection. Environment, definitely a hospital environment is more a vulnerable environment, an environment which provides more and more positive environment for the microorganisms to grow. And these factors can be the location of the hospital. Mostly if I talk about the location, it is ICU, operation theater, post-operative wards. Maybe patient has undergone the diagnostic procedures, immunosuppressive, chemotherapeutic. Right now we are celebrating the world observing, rather I cannot say it is a world antibiotic awareness week. Why wow week we say it as. So we are observing just to preserve all our antibiotic. Because of the hospital overuse of them, the environment is prone to invite more and more organisms to grow. Surgical intervention, medical intervention, asymptomatic carriers. So these are all environmental factors. Again, the organism, if we talk about the agent, like, and variety of the microorganisms are there which are lying in our reservoir, which are lying in the hospital, fomites, hospital environment. And these all have grown to certain level that they have acquired the multi-drug resistance. So the 10 years back, the scenario was little different. Now in ICU settings, we have nothing to save the life of the patient in terms that it will target the organism or the bug which has infected the patient. So these three, when they come together, they will infect the patient in a hospital setting, and it will be called as the healthcare associated infection. So if I tell you about the burden of the healthcare associated infection in LMIC is low middle income countries like our country, you can see the red, that is a more than you can see in India, you can see the graph that quite a bit is covered, and it is 2020 data only. So if we go and see the next 5 years data are yet to be published. So we know and we see that what is the burden, it is increasing and increasing only. So mostly if I talk about the healthcare associated infection, 7 to 10% of every 100 hospitalized patient are infected by healthcare associated infections. 7 in high income and 10 in the low income. They will acquire any of the one of the healthcare associated infection. 1 in 4 of the healthcare associated infection are more seen in the long-term acute care setting and also caused by the multi-drug resistant organism. And 1 in 3 are seen in the ICU setting in high income, but and out of them at least one will be having the multi-drug resistant organism, infected by the multi-drug resistant organism. So this is really important. And the most adverse events during the healthcare delivery is the healthcare associated infection. And why we are concerned about it? Because it will I represent a government organization. So in my organization, like, every treatment is free of cost, but wherever the patient has to pay, it will increase the cost on the health system. But even though they need not to pay in the government settings, the burden of the prolonged stay is going to be there. Long term disability will be there. Additional costs to the health system it will add on, and it will increase the resistance to the antimicrobial agents and additional cost. Yeah, Arjun, I am in a lecture. I'll call you. Yeah. So, you know, these all will be so largely, but very importantly, very important fact about the healthcare associated infection is that these healthcare associated infection can be prevented. I never say, and it cannot be sure shot that it can be reduced to 0% because of the environmental factor and all, which are not under our control, but it can be prevented to certain level by adopting some simple solutions, and which is very very important and which is very meaningful and can be implemented in any of the healthcare settings. So it is one of the important patient safety goals, and control of the healthcare associated infection is one of the important pillar for the national patient safety implementation framework, and it is one of the priority area, an important priority under the AMR containment also. So when we talk about healthcare associated infection or about the IPC practices, how we can intervene and how we can, implement these practices. So first and foremost is, a rapid and accurate diagnosis of the organism. So if you diagnose it, you can target it so that it will not be infecting the others. And most important, these all, it is made in a chain shape. So, as a healthcare professional, what is our duty? Our duty is to break this chain of transmission of infection. So, any of the healthcare worker, healthcare professional has to target to break the chain of transmission of these infection, and that is what is the basic of the IPC practices. So rapid accurate identification of the organism is very very important to target them. Then environment, like reservoir, if you see the hospital environment, hospital environment contribute a lot in transmission of healthcare associated infection. So we need to have the proper environmental disinfection and sterilization protocols in place. Also the employee health has to be taken in account. Then second is the portal of entry. So how they enter, mostly when we have a breach in the continuity of the skin or any of the mucosa, they will try to enter. So portal of entry we can prevent by, like if you see a surgery is a surgery will be always be occurring in a environmentally controlled setting, which we call as a operating theaters or operating rooms, wherein we will have everything, the HEPA filters and all, so that all entire thing is in such a way that transmission of infection from one patient to another does not occur. So this proper attire is also very very important. So like you have seen that after scrubbing, the surgeon wears the entire set of gown, clothes, entire PPE. Hand hygiene, it is one of the simplest and the best solution to reduce the healthcare associated infection up to 60%, and it has been proven by many of the studies and has been published in many of the literature also. How biomedical waste management, so it is one of the source of the healthcare associated infection. So appropriate segregation of the biomedical waste and its disposal, these all plays a very important role. Control of the excretions and secretions which are all coming out of the patient. Then means of the transmission, we all know that it can be transmitted by air, water, from person to person, cross transmission, all are possible. So what will happen, like we need to target on all these transmission modes. So these can be targeted very well by the hand hygiene, and by the isolation precautions in the OT, by the airflow control, sterilization and disinfection, and portal of exit, like from any of the catheter, wound, from secretions, excretions, it will be exiting out of the patient body and will be infecting the other patient. So recognition of these all high risk client, and then treating the underlying disease also makes it important, because the host susceptibility will be then will be reduced to these infectious agents. So these breaking the chain of transmission of infection is very very important. It is a key concept. It has to be it is the responsibility of all the healthcare professional to target this chain and break this chain, so that less number of the patient are infected after coming inside the hospital. So for that, we need to have a IPC plan. We tell it as a a smart plan, we say. So it depends upon the surveillance, monitoring and auditing, antibiotic policy, reporting and isolation of the disease, including the outbreak management, and also the training of the staff and staff health. So when we when we implement a smart plan, most of the time, and in a in a scientific logical way, definitely the rate of the hospital acquired infection reduces and our IPC comes into the practice. So if I tell you how this plan needs to be, the IPC basics of the infection prevention and control program. So first and foremost part of this program, that it needs to be documented, because we say that anything which is documented is done. Anything which is not documented, we don't know what is going to happen to it, and no one, and no one can be held accountable for that. So first and foremost, you need to have a structural infection prevention and control program which is well documented, which has all aims and objective, processes, surveillance procedure, which is based on the organizational priorities, current scientific knowledge, also on the national and international guidelines and professional bodies and statutory requirement. But it has to be written. It has to be written down, and it has to be reviewed also once in a year. That is what is we said. Reviewed means we need to review it in appropriate manner, and if any guidelines gets updated, we need to update our IPC program, which is a well documented program. And if we say we document it in a form of, every hospital document it in a form of hospital infection and prevention control manual. So this is very, very mandatory and very, very basic of doing it. Then what do we document? So importantly, we need to identify all the high risk activities wherein we will be targeting more vigorously, and these activities are called as like examples are handling the blood body fluids, handling the contaminated equipment, handling the biomedical waste, aerosol generating procedures like intubation and all, during the operations, splashes, and all these are very, very high risk activities, and potential risk of transmission of infection to the to patient and the healthcare provider is very, very high in these activities. So, and then these I have already told you, based on the new literature, new trend, we need to update and review and update this IPC program once in a year. It's not necessary that we need to, it's not necessary that this plan, this program, once you review it, there are changes. There may be changes, there may not be changes in the program, but we need to review it to incorporate the updated thing in the literature at the global level and the national level and at your institutional, or I can say the state level. We also say that before building this program, we need to use certain tools, which is called as an infection prevention and control risk assessment tool. And these tools are freely available on the Google, on the websites, on the internet. When you Google the WHO IPC IFCAF tool and CDC long-term control acute care hospitals tool, it will come. So it will be when you use this tool and do the baseline assessment of your hospital or your organization, you will come to know where we stand and how much we need to improve and what are all areas of concern for us. So these way we can implement our IPC protocols in a better manner, in a targeted way. So to implement the entire IPC program, a multidisciplinary committee has to be there, which coordinates all the infection prevention and control activities. So who all can be the committee members? Committee members can be the hospital administrator, microbiologist, infection control specialist, surgeon, infection control officer, infection control nurses, the nursing may be there, CSSD, OT, all support services like security is very important support services, which should be incorporated as a part of it. You can invite all the other members from different various other departments also. So, you know, dietary department it is also linen, laundry. These are all support services which are the part of it. And it contribute a lot in, you know, in preventing. If you implement the protocols, it contribute a lot in preventing the healthcare associated infection and bringing down the rates and numbers. So responsibility of this committee is to lay down the guideline, lay down the risk reduction goal and its measurable objectives, and at least annually, and review it monthly. And we need to monitor the trend, whether these rate of infection is going high, low, whatever is there, where we need to target. These all very importantly, they need to meet properly with a minimum quorum, and the minutes of meeting needs to be minutized, needs to be documented. And infection control team is there. So here we learned about the infection control committee, but the infection control committee will be all, you know, the big bosses or the HODs, HOUs of your organization. So it's not necessary that they will be participating in the implementation of the day-to-day activities. So to do it in an appropriate manner, to do it in an effective manner, we need to have an infection prevention and control team. So who all are there? They will be our daily, you know, ground level staff, the grassroots staff, which mostly go to the every nook and corner of the hospital on a daily basis, and they are basically eyes and ears of the infection control committee to tell them the exact scenario, what is happening in our own hospital, you know, in terms of the infection prevention and control. So where are the they will, you know, they will tell you where are the consumables, the supplies are lacking, where are the practices are lacking, where are, you know, some structural changes needs to be there, hand hygiene area is not there, taps are not working. So these all sort of, you know, daily activity they will be doing. Who all can be member of this? Two important: infection control officer and nurse, and definitely the nursing superintendent, the CSSD in charge, the housekeeping in charge, you know, the sanitary supervisor. These all are the part of it. And we always say that take a biomedical engineer also in the part of the team, so that, you know, day-to-day equipment maintenance and, you know, the environmental control part, like of the OT validation, HEPA filter, these all will be taken care by. You won't be able, even alone, you won't be able to understand the entire engineering aspect of it. So they should also be the part of it. What they will do? They will do daily surveillance activities. If a number of, there is a you know, a sudden increase in the number of the cases of a particular organism, particular infection, we say it as an outbreak, they will detect that, and they will do the day-to-day basis the infection control audits. Okay, and they will report to the infection control committee. So these are important. Who can be the infection control officer? Infectious disease specialist, a microbiologist with a knowledge of the infection prevention and control. Here I would like to add, whosoever is you know, a minimum qualified for this and is willing to do this activity, because it is a thankless job. It is a, you know, it is a job wherein you can't expect everyone. It's a job wherein you have to be highly motivated to do it on a regular basis. Every now and then there will be, you know, you will be in conflict with the entire team, entire you know, clinical staff, even your lower staff. To get it implemented, it needs a very high level of the motivation, and definitely a very close coordinated activity needs to be done with entire team member upside down. Infection control nurse should be there. So very important for infection control nurse, she should have gone through a structured training. Structured training means she should know about the basics of the infection prevention and control practices, because if she is not knowledgeable, if she is a simple nurse upgraded to the infection control nurse, she will not be able to percolate down to all the entire nursing staff, because she has to conduct a lot of training program, handhold, and, you know, do a lot of surveillance activity so that this IPC program can be implemented in our hospital setting. And at a minimum, we say that dedicatedly 250 bed, one nurse, infection control nurse is required. Now there is one new concept has come, which is called as a concept of the link nurses. So, like I work in a hospital setting which is 3,200 beds. So, whatever the number of the infection control nurse you keep, it's a huge setting. So, in any of the smaller setting also, to get it dedicatedly done, these nurses should be, linked to certain link nurses who are proactive members of the nursing department, and they are actively participating in these type of the activity. So they will be, reporting to the infection control nurse of these that particular area. So it will be this IPC practices can be implemented in a better manner with the help of the link nurses. Their responsibilities is the hand hygiene, compliance monitoring, working on the outbreak, education and training, and surveillance of the healthcare associated infection. And the compliance monitoring needs to be for the hand hygiene, for the isolation precaution, transmission based precaution, the care bundles, sterilization, disinfection, these all can be done through a checklist base. So outbreak management, definitely very, very important. So communication both internally and externally is very, very important. And first and foremost is to identify the outbreak. So, if your nurse is trained, if your staff nurses are well trained, if your link nurses are trained, they only, and even like we microbiologists, when we, with the help of the LIMS, that is a laboratory information management system, we can see that there are increase in the trend, or there is a clustering of 4 or 5 cases with the same organism infection like MRSA and all in a single ward. We immediately report to our infection control team, and the action taken can be done. So it can be through the trend analysis, or it can be through the active surveillance when these infection control nurses are going to these departments every day. And intervention has to be done immediately for this, so that it doesn't spread to other patients lying down there in the same ward, or same ward or ICU, or it doesn't spread to the community also. Very important IPC practices, we talk a lot about it, but nothing can happen if we don't have the vitamin M, and that is called as a money. And money has to be percolated down. Money, men, material, and all resources are percolated down through the management. So if you don't have a committed, if you don't have a top level committed management, they will not be providing you the infection resources for to run this, implement this infection prevention and control program. And because why they will not be giving you that, this management will not be interested into it, because it is not generating any money for the organization. So it is not a profit making practice, but indirectly it reduces the hospital cost, and also it reduces the patient cost. So indirectly it is generating, or I can say the saving money, but there is no direct generation of the revenue. So it is not liked by the management many a times. So you need to statistically, logically, scientifically, convince your management to provide the available resources, and say that it is very, very important for the organization to reduce the rate of the healthcare and associated infection by implementing the infection prevention and control program. So earmark budget is needed, and with the previous year's experience, they can have the earmark budget. So adequate supplies definitely has to be there. If you don't have the hand, if you don't have the personal protective equipment, if you don't have the hand hygiene, the consumables for the hand hygiene, that is the hand rub, hand wash solutions, water supply, these all are very, very important. So at every point of use, the adequate supply of all the inventories are supposed to be there. Then facility for the hand hygiene is very, very important. Hand hygiene also has got a few technicalities into it. One important is the Hand wash facility has to be have a large wash basins, not a small from where everything splashes out. Supplies of the liquid soap and a hand-free tap. It can be a push, it can be elbow operated. These all, it can be a foot operated, but it should not be like you are, touching it again and again to close and open it. And facility of the hand drying without the contamination. Hand rub facility dispensers can be, installed at convenience point, and staff carries out their own hand rub in between the patient movement. So at least once easily accessible, and also very importantly for the hand wash, the continuous supply of the water, uninterrupted supply of the water. So ensure all these availability, and then only this practice can be followed. One is important is the isolation and the barrier nursing facility at the hospital settings. So very importantly, those who are already infected, like having the airborne and having the airborne infection, or we suspect them. Like the greatest of the example is our pandemic of the COVID, wherein mm, we all were knowing that it is an airborne infection and can be transmitted through the airborne. So we took all the barrier or isolation precaution to prevent this transmission from one patient to another. One important example is the tuberculosis, H1N1 infection, okay, the influenza infection. So these all patients, when we come to know, we need to place them in a typical isolation room wherein negative pressure is there. So the air from outside can come due to the negative pressure, dilute the infected air inside, but cannot go. So exhaust air has to go through the, after the burnt out, or being decontaminated, or can be directly diluted into the atmospheric air, which is not nearby to the residential settings. Okay, the door closures has to be there. You can open the door without touching it. So sensor type of the door, or having a knobs, and an IL room, special room, wherein these barrier nursing facilities can be appropriately maintained. Appropriate signages has to be there. So these all are the for the isolation and the barrier nursing facility. Most important is adhering to the standard precaution. What we call standard precaution is one of the fundamental tenets of the IPC practices, and has to be followed all areas of the organization and all the time. That is what is the dictum, that is, and it is supposed to be followed religiously by each and every healthcare worker. And the first and foremost for the standard precaution is the hand hygiene. So one important thing is adhering to these guidelines and display near the hand washing area, because this hand hygiene is basically, has to be done during these 5 movements, that is before touching the patient, after touching the patient, before doing any aseptic procedure, after touching after exposure to blood and body fluids, and after touching the patient surrounding. So this is a very, very important, that we need to have we need to get our hands clean at least during these 5 movements. And how? So either by the soap and water, or by alcohol based hand rub, or if you are going to do any aseptic procedure, it needs to be a surgical hand. It is not rub, it is scrub. One important type of the hand wash we call as a social hand wash. Social hand wash is something wherein, socially you go for some party and all, and you wash your hand. It is not at all a scientific way of washing your hands. In a healthcare setting, it is always a hygienic hand wash, or a surgical scrub. So these are the 7 moments of the WHO hand hygiene, has to be followed in a sequential manner. And the hand, then after the hand rub or hand wash, after the hand rub, you can dry the hands anytime, because if it is alcohol based, it will dry by itself. But if you do the hand wash, you need to dry your hand before starting any of the or before touching the patient or any of the doing any of the patient care activities. So these are the steps. Everyone knows that this is all Suman ke Sida Ulta Muthi and all. This is surgical hand wash. Herein you see the size of the scrub station. You know, it is very deep, continuous supply. It is all foot operated. You need not to, touch these taps because it will contaminate to your hand. And it is scrubbing. It is not hand wash. Then comes the transmission based precaution. So transmission based precaution, like from one patient, we know that this patient is infected, and it can be transmitted either through the airborne droplet or through the contact. Like airborne droplet, I have already given you the example. Contact is the measles, mumps, rubella patient, or any of the a patient who is having the infected wound or skin infection. So therein we need to follow all the transmission based precaution and use the appropriate PPE accordingly. Then safe injection and infusion practices. So these all are, this is a 1 in 1 hour. It is not possible to take the session of the IPC. So I'm giving you the glimpses of it. And now the organization adheres to the safe injection and infusion practices. This is one of the important part of the IPC practices. So the dictum is one needle, one syringe, and only one time. So reuse is absolutely banned. Recapping is also banned, and we need to discard it in a puncture-proof, tamper-proof container so that it doesn't cause the needle stick injury to those who are handling it. Then important aspect of it nowadays, I have talked to you a lot about the healthcare associated infection with the multi-drug resistant organism. So appropriate use of the antimicrobial agent. So here in your microbiology department will help you, and to define and design and give you and prepare the antibiograms so that accordingly you can prepare the hospital antibiotic uses policy, and accordingly you can monitor it. So this policy is also empirical policy for common conditions, common infective condition, and as well as it is also it is also a policy for the prophylaxis antibiotic, which we give just before or one shot before the surgery. So these two parts are mostly covered, and the good reference is the ICMR guidelines. They have made one app on the Google, and you can very freely download it, those app, and you can have it on your mobile. What are the common standard treatment guidelines, antibiotic therapy guidelines for the commonest of the disease in our country? Okay, so these are basically based on the local antimicrobial uses and should be reviewed at least every year, depending upon its applicability. So appropriate antimicrobial uses policy is established and documented and reviewed also. Then it is documented and reviewed, that is all fine. Are we following it or not? So then we need to monitor it, and most important way of monitoring it, that we know that we don't have anything in the pipeline right now. There are some restricted antibiotic agent, so if they are freely available and used in our hospital setting, they need to be restricted. And at least as a part of the antimicrobial stewardship program, you need to tell the entire team of the consultants that no, you cannot use it just like that. There should be some logic behind that, that the test result has come shown all drug resistant organism and all. So a justifiable way, you need to use the restricted antimicrobial agents. Antibiotic stewardship program, it is very difficult to implement. One of the most challenging area in the IPC program implementation. And then comes the engineering control to prevent the infections. Engineering control, when we say the control of the hospital setting, it has two parts. The designing of the patient care areas, that is between two beds, 1 to 2 meters of the space is necessary. Negative pressure room, operation theaters. So these all are operation theaters are the positive pressure rooms. So these all are the design controls. Okay, designing control, infection control practices by hospital engineering controls. Then we need to have the air quality check, maintenance of all the our heat ventilation and air conditioning system, cleaning of the duct, cleaning of the filters, replacement of it, prevention of the fungal colonization. Apart from that, the water management is also very important, because we know that water is also one of the source of transmission of infection. So these systems of the water supply and testing of the water supply, minimum microbiological testing at least once a month, and 3 monthly biochemical testing is advised. The organization designs and implements a plan to reduce the risk of infection during the construction, and this we called as the infection control risk assessment. One we saw in the initial of my presentation, that is a baseline risk assessment. Second is whenever you want to change in the structure, any construction activities is going on, at that time also we need to do the risk assessment in terms of the infection control. Also this is called as a ICRA, that is the inspection control risk assessment, and PICRA we called is at the pre-construction risk assessment. This has to be done so that we can take adequate uh, preventive measures for that. Okay, like during the renovation we need to barricade that area, and the use of the material and all, these all are supposed to be planned by the IPC team. Then comes the housekeeping procedures. So housekeeping, so for this ICRA, the CDC has given very nice tool. You can Google it and find it and download it. Then for the housekeeping procedures, again it is on the risk assessment and risk matrix. So we all know, as per the Swachhata guidelines, Kayakalp guidelines, our all hospital areas are categorized into the critical, semi-critical and the non-critical areas. So all the admin goes into that, and critical and the semi-critical areas are supposed to be in a standardized way. The protocols needs to be developed. Okay, so the cleaning has to be regularly done. For that, the frequency of the cleaning is depending upon the critical, semi-critical and the non-critical areas, and physical environment, how and also we need to see the number of the patient, number of the activity, number of the probability of exposure to the blood and body fluid. Like for example, in the OT and lab and ICU, we need to clean it again and again. Adhering to the housekeeping practices, we need to hospital approved disinfectant solution. Means the committee will decide that which disinfectant solution is supposed to be procured for the entire year, what are its dilution protocols, how it works, the terminal cleaning protocols. So these all you can refer to the CDC guidelines. It's a preferable to follow the uniform housekeeping policy across all the different departments. And dry dusting is prohibited in patient care areas. So please take out all the dry mops, or I will say the brooms, from across the organization, except for the admin areas. You can't use them in the patient care areas. It has to be the wet mopping only. Then comes the biomedical handling of this. I think elaboratively people have taken the sessions on it. I will only say that segregate at the site of generation, which is the mantra for the biomedical waste management, and it needs to be, the entire process needs to be monitored by the IPC team and also by the process. Then the linen and laundry. We all know that our linen also becomes a source of the infection. So as per the Government of India guidelines, 7-day color-coded linen practice is followed in many of the healthcare organization. And also the storage and distribution of the clean linen, how it is stored, disinfection of the infected linen in the 1% hypochlorite solution, visiting of the outsourced services. These all are the part of the IPC practices. And then kitchen is also can be one of the source of infection, because of the food poisoning can occur. Screening of all the food handlers, preparing preparing, handling, storing, and distributing it in a safe manner, no crisscrossing, and separate food preparation area, storage area, dry, wet storage. These all needs to be monitored and seen from time to time, so that due to the food, the infection doesn't occur in the patient. Okay, so these are all this is all about, like, store the food off the floor, ensure the flies and insects. So pest control activity, supplies should be located in a clean supplies should be located a little far off. Refrigeration needs to be controlled. Then comes the surveillance activity. So surveillance activity, majorly we do the 4 type of the surveillance, which are as per the CDC protocols, the healthcare associated infections. So 3 are the device associated infection, and 1 is the procedure associated infection. So it is said that the device attributes to the increase in the probability of healthcare associated infection, and hence we need to hence these device associated infection. Samra, I am in a lecture, I will call you. I am in a lecture, I will call you back. So a device associated infection, and these can be because of the external devices, medical devices like catheter, ventilator, central line, and there are care bundles already. So set of the infection prevention and control practices which will help you to reduce this infection in your setting. And these bundles are developed like, they are developed like the insertion bundle, when you insert it in a patient, and one is a maintenance bundle. Every day you need to observe whether these care bundles are being adhered to or not. So I'm not going into the detail of it. And the fourth one is the procedure associated, and that is what is called as a surgical site infection. So adherence to the standard precaution, transmission based precaution, pre-op, intra-op, and a post-op measures or care bundles will prevent the surgical site infection. And tracking of this is very, very important. Validation of data is also important, and surveillance of these activities are also very, very important. And surveillance and monitoring of the hand hygiene compliance is also important. So it is said that at least once a month we need to. So WHO, when you search that hand hygiene surveillance, WHO's hand hygiene observation form is freely available. You can see that they ask us to monitor 8 opportunities for one single category of the staff, and in that form you can fill it for the 3 category of the staff, the doctor, nurses, the paramedics, the housekeeping, and all. And then, like, opportunities we count. Initially I have shown you one slide, the 5 movements of hand hygiene. Depending upon those opportunities, you can see that they have all chances to wash the hand, but they didn't. So that is the we will say that is a non-compliance. So that we calculate as a rate cadre wise. So this needs to be done. Multi-drug resistant organism, and effectiveness of housekeeping practices. Feedback is very, very important. Whatever we do the surveillance, it needs to be percolated down to the ground staff who is doing it. Because if your data doesn't percolate, data collection, surveillance is nothing, it is data collection for action. If it doesn't go to the to the ground staff, they are not going to change their practices. They are not going to change their mindset. They are not. So it is what we say, that we need to talk to each and every level of the staff to percolate it down and to adhere to the practices. Outbreak management, I have already told you, early identification is very, very important, and handle it as per the written guidelines. Then corrective and preventive action has to be taken after the analysis of the data by the infection control committee. Now we come to a very important part of the hospital infection program, that is the central sterile supply department. Most important of this is that it should be located suitably in such an area that it is nearby to the operation theater. Second thing is the zoning of this. Zoning means that there is no crisscrossing. So, it is either U-shaped or it is unidirectional flow. So the dirty area, soiled area, the clean zone and the sterile zone should come one by one. It is not like that the soiled and sterile zone lie side by side. So, you receive the article, the infected article or used article at one end, and you issue the sterile article from the other end. A separate clean and dirty area has to be there, and sufficient space has to be there. Then, importantly, it is removing of the biological material or the bioburden from that particular instrument. And sterilization, we say disinfection kills all the organism. Sterilization, it also kills the spores. So importantly, that how do we decide which method is supposed to be used in which set of patients? So if it is patient contact is intact skin, it is a low level or intermediate level disinfection is okay. If it is a mucous membrane or non-contact skin, then high level disinfection like glutaraldehyde solution, Cidex OPA solution, or I would like to say even with the hypochlorite hydrogen peroxide and all. Okay, and if it is entering inside the major vessels of the body or comes into the contact of the blood, then it is a critical. And here only sterilization, either autoclaving or I would say the ETO sterilization or the plasma sterilization. So, the cleaning, packing, disinfection and sterilization, storing and issue of the item is done as per the written guidance, and clean use item has to be supplied. Okay, and also the validation of the entire process needs to be done. And if you are using a single use device, you need to mark it that how many times you can use, which method you will be using, and it should be in as per good consonance, in consonance with the good practices. So validation can be physical daily, so you can monitor the temperature, pressure, chemical strips by strips, and at least weekly bacteriological. Engineering validations are the Bovidic test, or we say it as the load test and the leak test. Okay. So breakdown in the sterilization system, if anything occurs at any time, we need to withdraw the load. So there is something called as a recall. So once any of these indicator fails, we cannot issue the load. If it is already issued, we need to recall it back to us and do the root cause analysis and see that where the error was, and open it, clean it again, dry, pack, and put it in another sterilizer which is working. Most of the time the failure is because the steam is not generated properly in the autoclave, and because of that, there is some leakage inside the autoclaving because of the gasket or some coil issues and all, and these can be taken care of. Then comes the occupational health and safety practices. So adequate resource has to be provided, standard precaution, pre-employment health screening is important, and also the hospital immunization policy. Two to three important vaccine we need to take. One is the hepatitis B, second is the tetanus toxoid, third is for the healthcare worker, those who are working in the kitchen or the dietary department, directly exposed to the food, they need to be vaccinated for the typhoid. Okay, and COVID vaccination, definitely those who are willing we have taken during the pandemic. And we need to limit the roles and responsibility of the infected staff, so we need to screen them. So common transmissible disease we have, if we have a severe respiratory infection, smear positive, do not send them to the wards. Okay, do give them some administrative activities so that they can do certain other work with the appropriate personal protective equipment, but they should not be exposed directly to the patients. And needle stick injury, it happens, so we need to have a needle devices with the safety features and the personal protective equipment to be worn, and personal protect and post exposure prophylaxis in case of exposure to blood and body fluid or after the needle stick injury, and maintain the records of all the things. So this is all about the IPC practices. So our entire role is breaking the chain of transmission, and it is a very, very big responsibility. and a systemic change has to happen, and it has to come into the it should become your second habit to implement, or I would say, the observe the IPC practices. So thank you so much for your patient listening. Hello. Hello. Hello.
Yes, ma'am.
Yeah, so can I take a 5 minutes break before I go for the next session? Will that be fine?
Sure,
Yes,
ma'am.
ma'am.
Ma'am, I had a question about the last session.
Can you ask entire thing together after we complete?
Done, done, ma'am.
Okay, so give me a 5 minutes, 5, 7 minutes time. I will come back with your second session. Okay.
Done, ma'am.
Yeah.
ये ऑनलाइन कर रही है कि कॉलेज वाले कर रहे हैं
Hello.
Yeah, hello,
Yes,
ma'am.
ma'am.
Yeah. So I will be starting my next session, that is impact of the infectious and hazardous waste on the human health and the environment. And most of the things you all know. So I will be, only briefing you on certain important key points wherein you need to focus as per exam point of view and all. So starting it, I will. I think there is some problem with sharing my screen. Shall I continue it just like that? Is that fine?
Yes, ma'am.
Okay. So basically, when we talk about the environmental, when we talk about the impact of the infectious and hazardous waste, so you all know the in the category of the infectious waste will come all the biomedical waste, and hazardous waste are different than that, and that can be the various, chemical waste, radioactive waste, pressurized vessels, heavy metals, radiological waste. So these all comes under the category of the hazardous waste. So starting, I will be sticking only to the few focus points, that how it affects the human health and what are the prevention points we need to take. Not apart from that, not the detailing of it, because in view of the time will not be going into the detail of it. And when we talk about it, that what are the various risks associated with the medical waste, we say. So first and foremost is the effect of all the physical pollutants it has. So if we talk about the physical pollutants will be the byproduct of all the incineration which is being done for the biomedical waste. The heavy metals also comes under it, and the physical injuries by the sharps and the needle. So the dioxins, the furans and all, which not only affects the human health, it also affects, it is highly toxic to the environment also. There are certain toxic metals like mercury, cadmium, when they are incinerated, they release the neurotoxic waste, and probably these all are carcinogenic also. It affects a lot, it physically affects a lot, irritates our eyes and the respiratory system. So this is the side effects of the physical pollutants. Physical injuries, when we talk about these sort of waste, if they are not segregated appropriately, the sharp waste are very dangerous category of the waste. And we say that's why it is said that it has to be segregated at the site of generation. If you don't do that, there are all chances that of 30% high transmission of the hepatitis B virus infection than the HIV infection. And hence it is said that wearing of the appropriate heavy duty gloves, and this all occurs, while the waste handlers are doing it, because they are uneducated class of the people, and they are not highly bothered about their own health, and they will be doing it. Not only this, in the emergency settings, many a times in the ICU settings, therein, to save the life of a patient, or maybe casually the nursing will be recapping it, and because of that you get a injury from this. So these are all the physical things which is occurring, and this is leading down to all these health effects. Now we come to the chemical pollutants or chemical waste risk. So chemical waste are basically, these are the drugs. Some of the hazardous chemicals are what? These are mostly the chemicals, either they are used in the lab or they are the cytotoxic or the radioactive drugs. So if these chemotherapeutic, radioactive, these all, they are drugs are not used, in an appropriate manner as per the laid down guidelines, they can lead to a lot of hazard to the common man or those who are handling it. One important chemical, formaldehyde. Now it is mostly these aldehydes are now banned, except for the pathology department. Autopsy and embalming, it is not used, and there also it is too irritant. So we need to take care appropriately. And in pathology, in the histopathology, there the level of the formalin gas is also mapped and monitored. So if you are not monitoring it beyond certain level, it becomes highly toxic to the human body. Photographic chemicals like fixer developers in the radiology department, the solvents like chloroforms, these all mercury, ethylene oxide in the CSSD department. So these all chemicals, you need to have the material safety data sheets for them, and you also need to prepare the action taken when you get exposed to them. So the when there is a hazardous material spill, how do you handle it? So that these two things becomes very, very important. These chemical injuries can be toxic, corrosive, flammable, genotoxic. It can be anything. It can be a chemical burn, it can be a cytotoxic cytotoxicity. So the severity can lay down up to any level. So if I talk like acid, if I talk about the acid, it can lead to its toxic effect. It can lead to the corrosion. Alcohol chemicals will lead to the CNS depression and all. Aldehydes causes a major CNS depression and gastroenteritis. Glutaraldehyde can cause mucosal irritation and other compounds, heavy metals. They can cause the shutdown of the renal system. Mm, the oxidant will cause the anemias, hemolytic anemias. Phenols can cause the skin burns. So these are all some of the toxic effect of these compounds if they are not used in an appropriate way. Then we come to the biological pollutants. So biological pollutants are the biomedical waste, human anatomical waste parts, and all these are all the the part of the biological waste. So mostly what will happen in the biological waste, we call is also called as a biomedical waste also. We all know it can lead to transmission of infection up to any level. It can lead to needle stick injury. It can lead to environmental pollution. It can lead to transmission infection not only to the healthcare worker but also to the community. So this we have to take it very sensitively, and we cannot it cannot be done just like that. So as per, and it is a legal binding, so we need to follow all the protocols laid down by the pollution control board for these dealing with these biological waste or biomedical waste, if I say. Then comes the radiological pollutants. They are the sources of the radiological waste in the hospital are mostly the radiation therapy department, the radiology imaging department, radionucleotides. Very importantly, this is also a legal binding, and herein what will happen, as per the AERB guideline, Atomic Energy Research Board guidelines, we need to follow it. So depending upon their half-life activity, they need to be discarded accordingly in the closed container. This activity will be monitored, and all this has to be done. But if these waste if these waste are exposed to the human, how what will happen to them? So mostly the serious they are highly mutative. It can affect the body cells also, right from ranging from the headache, dizziness, vomiting. Serious problems can also occur. So it is genotoxic also. So with utmost care it has to be discarded. And the waste handler, so we all know that radiological the radiation therapy and the I will say for the cancer therapy, the radioactive nucleotides treatment, these all cannot be given until and unless you are licensed to do that. So what we need to do basically, we first need to prevent the spread of these waste in the environment, and second, if at all it happens, we need to treat that particular patients, okay, or the healthcare worker. Mostly it will not happen to the patient, rather it will happen to the healthcare worker. So this is I have all elaborated you about all the IPC practices which are supposed to be followed, and the waste management also is the part of it. The risk of healthcare system to this waste is very much if the IPC protocols are not followed appropriately, and it becomes a public health risk hazard also. Like it can cause a lot of gastroenteritic infection, respiratory infection, even HIV or hepatitis B if the rag pickers collect those needles and all. So infectious waste is, among all these three, the infectious waste is highly, I would say, a very high risk category, and the rate of transmission not only to the healthcare professional but also to the community lies into it. And hence we need to follow all the biomedical waste management guidelines very religiously, and it can lead to the occupational hazard in a very huge quantum. So I think this is all about the impact of, because I have briefed almost all part of it. So I am done with my sessions. If you have any questions and queries, you can definitely ask.
What are the halogens?
Yes.
What are the high halogens content?
Pardon. You are not audible, sir.
I just asking what are the high halogen content?
Can you type it, because your voice is echoing?
Yeah.
Can you type it in the chat box?
Yes, yes.
Oh, what is high halogen content you are asking? Okay, so mostly the disinfectants which we are using in the hospital, which are, if I tell you about the chlorinated halogens are there. Okay, so they contain, if they are used at a higher level, they are highly corrosive and can give rise to a lot of health hazards. So they also has to be used in a calculated way as per the disinfectant guidelines. Mostly the iodines and and chlorines are the halogens which we use in a hospital on a common basis.
Ma'am, should we neutralize or minimizes the uses?
Yeah, we should see as per the Pollution Control Board guidelines, that is the Central Pollution Control Board and the State Pollution Control Board guidelines. They wanted to make it chlorine free. Okay, so the other disinfectant solution which can be used inside the hospital are promoted. Maybe the the hydrogen peroxide or any chlorhexidine based compound, they all are being used. So they are reducing. So aldehydes and chlorinated compounds are reduced, are supposed to be reduced as per the advisory of the government. Any other questions?
Yes, ma'am. You said that this dry mopping is not to be done in hospital areas. So what about the flat dry mops that are
Can
there?
can you type it, because your voice is very feeble.
Can you hear me now, ma'am?
Mm, yeah, can you speak it little loudly? Maybe it may be a problem from my end also, but can you speak
Uh,
it little loudly?
yes. Can you hear me now, ma'am?
Yes.
Yes. So you said that dry mops cannot be like used in hospital areas. So
Yes.
what about the flat mops that we have, the dry ones?
The flat ones, in the lobby areas and all, you can use. Why we don't want to use it, and the guideline why they don't allow to use, because they will produce, the aerosols, and the small, I will say, the aerosolized dust will be produced because of that. And hence it is said that we should not be using it in the patient care areas. You can definitely use it in an admin area, but not in the patient care area. It is always to use the 3 bucket trolley system of the Swachhta Mission for the wet mopping of the patient care areas floors. Because if you do the dry dusting, a lot of spores will come out of it.
Okay, ma'am. And ma'am, is there a like a needle stick injury assessment form or something like that?
Yeah, needle stick injury assessment form. You can Google the NACO guidelines. The NACO guideline has given a very good risk assessment of the post-exposure prophylaxis. It will be based on it will be based on the status post and the exposure code. Exposure status code will be the other party. Like if you are exposed to the needle stick injury, you need to know the status of that particular patient, whether it is reactive to the HIV, not reactive, hepatitis B positive or not positive. Depending upon that, the NACO has given the protocols now how to give the post-exposure prophylaxis. Second is the exposure code. Exposure code, it is a hollow needle. It is a big needle. It is a sharp needle. It has entered deep into it. So these all assessment has to be done in your antiretroviral therapy center, that is the ART center, once the needle stick injury occurs. And once this entire assessment is done, you are put on the post-exposure prophylaxis drugs as per the or rather I would say post-exposure prophylaxis therapy. And after that also it is monitored for after 14 weeks, like after 2 weeks, then 14 weeks, then 28 weeks, and then after 6 months, because we don't know if the patient is a carrier and you are carrying that virus. So these all are given. If you Google it to NACO, the very well beautifully designed flow charts and the form is already given.
Okay, ma'am. That's it, ma'am. Thank you.
Any questions and queries from anyone else? So if we don't have any queries, we can, if you all allow, we can close the session. I think we can ask the organizers.
Can you give a timing of these sessions and classes? It will be changed or not?
What?
The timing of classes.
Timing of classes, you can get back to the organizers,
Okay.
because that is not decided by us.
Thank you.
It is I think decided in collaboration with Ruchika Kuba ma'am and the RC Bhubaneswar, I think. They contact each faculty member. You wanted a change in the timings of the session?
I get back that, ma'am, there is any change because yesterday I'm just log on, but the class is not going on.
Maybe you can ask for the pre-recorded version of these sessions to them on a request base. They will be provided. RC Bhubaneswar, can you comment on it? I think they are not joined. You can email to Ruchika Kuba ma'am. She is very proactive and she will reply to you. Don't worry. If at all you have any queries.
Okay. Thank you, ma'am.
Okay.
Ma'am,
Uh-huh.
so is it, I just found it, the NACO guidelines. So is it the PERP provider card and patient card? Is that it?
Yeah, see, this is they only provide you a broad guideline. Every hospital has to define their, because they are all the control document. They have to define and design their own card or formats or all. But all the aspect of it should be covered.
Okay.
So, if no more queries, we can close the session.
Yes, ma'am. Thank you, ma'am.
Okay. Thank you very much. Thank you everyone for your patient listening.
Thank you, ma'am.
Thank you.
Thank you, ma'am.